BBC London 94.9.
Vanessa Phelps.
Call 020 722 42000.
Good Lord, are we or are we not supposed to take statins over the age of 50? Would it be a great thing for us all to be put on statins so we don't die of heart attacks and strokes and things? Would it be brilliant? Would it be marvellous? Would it be a fantastic life-saving manoeuvre on the part of the government, meaning that we could live longer and see our grandchildren and our great-grandchildren and our great-great-grandchildren? It would be fabulous, wouldn't it, if we were all put on statins over the age of 50? Immediately on your 50th birthday, you get a lovely letter from your doctor saying, come and see me, I want to write you a prescription for statins. You take them and you live happily ever after to about 120 years old at least, in frolicsome form. Or are statins actually the very spawn of the devil because they give you such horrible side effects, some nasty kind of joint pains and arthritic pains and horrible other pains, that really we shouldn't take them at all? Is cholesterol a scourge? Is it not as bad as we're told it is if it's raised? Who the heck knows what to believe? You look at any newspaper today and you end up more confused than you were when you started. So let us ask Dr. Iqbal Malik, the cardiologist. Hello, Dr. Malik. Good morning. Welcome.
Good morning, Vanessa. How are you?
I'm all right, but I'm 52 and I'm not on statins. Should I be or shouldn't I be? Nobody knows what to do.
Well, I think I'm a believer in statins, so I'll have to declare that as a conflict of interest up front. And I put myself on a statin at the age of 48. In fact, I started when I was 46.
Did you?
I started thinking about it when I was about 45, because the primary prevention data, I'm Asian, but no other risk factors, and a cholesterol that's 5.2, so it's really not ballistically high. So I am a believer in primary prevention.
Right.
And there are a wealth of studies that say, look, if you have any elevated risk, and unfortunately being an Asian gives you a risk factor, then you should probably be getting onto a statin. However, a blanket policy to say that everyone over 50 is basically the only economical way of trying to get the whole population treated. So if I came to you and I said, look, when you're 50, stop smoking, no one would argue about that, because the evidence is very strong that smoking is very bad for you.
Yeah.
In the same way, I think what people have to realize is that what is a usual, not normal, usual cholesterol for the UK population is anything but normal, because our diet is not what our bodies were actually designed for. So a normal cholesterol for a human being is probably what Japan had when they were eating fish and not McDonald's. And so the usual cholesterol above 5 in the UK is not normal for the human body, and we do have a very high risk of coronary heart disease and stroke.
Yeah.
So the evidence would be that if we could lower that cholesterol to a more normal, not usual, but normal level for the human body, that our risk would be lower of having cardiovascular disease. It doesn't it doesn't make the coronary disease we have already go away, but what it does is it stabilizes everything. So if you imagine a wall that's falling apart, it's not giving you a new wall. What it's doing is it's plastering over and reinforcing the stuff that's there already, so that it doesn't rupture and it doesn't cause heart attacks and strokes. And there is a lot of evidence behind that. Now, the recent scare has been because of the article in the British Medical Journal just before Christmas, which somehow overblew the risks from statins, because it is a drug, and there is no drug with zero side effects. Not even a chalk tablet, if you take that in a placebo trial, well, it'll give you side effects. So there is no drug without side effects. So it is always a balance of risk between the benefits, which are proven, and the risks, which are also there. So if, in fact, you are someone who has one or two additional risk factors, so not only are you 50, but unfortunately you've been a smoker, not only are you 50, but of course you have diabetes, not only are you 50, but perhaps you have high blood pressure, well, in that situation, I think the evidence would be absolutely solid. So if you're asking the question, do you have a really good cholesterol, your GP measured it, it was actually low, you have no other cardiovascular risk factors, well then you probably don't need the statin. But having said that, it's much more expensive on a population level to do individual risk assessment than to say, on average, a UK 50-year-old, especially male, because unfortunately men have higher risk, should automatically get onto a statin, and if they have side effects, we'll review, but otherwise put them on it and forget about it, is quite a reasonable policy, and one that, I've advocated for myself and I've actually already started. So,
tell us a little bit about the potential side effects. What are the side effects caused by statins?
Okay, so most people will have none.
Right.
That muscle aches can certainly occur in some people. In 3 or 4% of people, you will get some muscle aches.
Let's just linger a little on those muscle aches, because somehow just saying muscle aches on the radio doesn't sound like much of a big deal. People think, it's a bit how I feel after I've been working out at the gym, no biggie. But actually, they can be, in some cases, I know not many, but they can be fairly paralysing, can't they, these muscle aches? They can be very, very painful.
I mean, I think I haven't ever come across a patient who was paralysed by the muscle pains, but actually it can be uncomfortable, and you also can get a sort of lingering fatigue. Now, if that does happen, first thing I do is to say, stop the statin for a couple of weeks and see if it all gets better.
Yes.
And if it does get better, I always restart the statin, because you do not know it is the drug until you have stopped it and you got better, and you have restarted it and you got worse again.
All right, let's imagine you get worse again, then what?
Okay, so you could try a lower dose of the statin, and there are several statins around, and not all of them do exactly the same thing. And so before I gave up on statins altogether, I would start on a lower dose and see if you could tolerate that. And if that didn't work, I'd switch to a different statin. Now, in this primary prevention, I'm over 50 statin group, if the second statin didn't work either, I'd accept defeat and say an alternative for you to lower cholesterol to get about 1/3 of the benefit at about 1/3 of the cost is to just take the plant sterols, the Benecol and the other sort of things with plant sterols, and you can get over the counter at your supermarket, and they do lower your cholesterol.
So they are worth it, aren't they? They're worth bothering with.
Well, they're worth it if you can't take a statin, because the problem is they have only about 1/3 of the effect of the statin. There's one other point I would make, Vanessa, and that is that I am not hung up on just the total cholesterol. I see a lot of ladies in particular where the total cholesterol might be 6.
Right.
And anything above 5 you begin to think about, and it's 6 and people get very het up about it. I would advise very strongly that, especially if there's a reluctance to take statins, it's the ratio of good to bad cholesterol that's really important. So the total cholesterol of 6, you need to know how much of that is the good stuff, the HDL cholesterol.
Yes.
Because if the HDL cholesterol, for example, is 2, then simple maths would say your ratio is 3-to-1. So 6 divided by 2, 3-to-1. No real imperative to give a statin. However, if your HDL cholesterol is only 1, then your ratio is 6-to-1. And at 6-to-1, I would be really pretty much advising the patient they really should be on a statin. Because if you have never had heart trouble or a stroke before, my target for that ratio is to be below 5-to-1. Right. Whereas if you've is below 5-to-1. If you've actually had vascular disease or you're diabetic, then I really want it below 4-to-1. So the sort of message I would have is that it's not all about just a single number, but a calculation of your overall risk and also the ratio of good to bad cholesterol. But if all of that can't be done on every single patient in the population, well then certainly I am in the camp of saying that over 50, you should ask yourself why you haven't been given the risk reduction benefit at quite low risk that a statin would offer, and a number of cardiologists are already doing it for themselves. The older you get, the more worried you become, and I am one of them.
And have you experienced any side effects at all as a result of taking the statin?
Not a jot.
Nothing at all?
Nothing at all. And I think that would be the majority of people, not a jot. Of course, I put people on statins all the time. And yes, I do have patients where they can only take it every other day, and that's what we settled on. Or they can take it in a lower dose than I initially started out at.
And is that simply the muscle pain thing? There's nothing else? They don't report, loss of libido or depression or headaches or dizzy spells or spots or anything else? It's just some people get muscle pain? Or is there anything else?
The specific side effect is muscle pain.
Right.
And if we're talking about side effects that really we don't even check for routinely unless you become unwell, then you can get some liver dysfunction. Now, I don't routinely check liver function tests after taking a statin. I haven't checked my own.
Yeah.
What I would do is if you start saying, look, I don't really feel very well, then I'd do some blood tests to actually make sure that it hadn't affected your liver. You're not in the less than 1% of patients that might have that problem. But those side effects, I think, have been slightly overblown. They do occur, but the signal is, I'm not feeling so well, doctor, and then we can check a little bit further to see what the problem is.
Okay, so at the very nub of this, Dr. Malik, the reason that you put yourself on statins at the age of 46, partly because you're Asian, but no other risk factors, you haven't got high cholesterol or anything else, is because you hope it will do what? It will stop, it will make you live longer, and it'll stop you having a heart attack or a stroke. Is that it? That's what you hope they'll do?
That's exactly it. So I think it's going to lower my overall risk of having a heart attack in particular and a stroke also. And that's why I'm taking it.
Okay, what do you advise my lovely listeners to do? Because they are lovely, and it would be nice if they live very long lives, and nobody wants them rushed into hospital with heart attacks or strokes. We don't want to pay for it. We don't want the suffering. We don't want the sorrow of the lovely grieving relatives. We don't want any of that. We all want to be healthy and live long lives. So do you think that my listeners should cascade towards their GPs and say, oi, I'm over 50, give me some statins right now? And if they do, will their GP say, okay, here you are, and just hand them over like Smarties, or will they say, well, no, we don't do that in this country yet?
Yeah, well, I think it's only just coming in this, so it's under discussion that we should be putting everyone over 50 here. But what GPs do like to do is that if you come in and say, look, what is my overall risk? There's a very easy calculator that looks at your body mass index, your smoking history, your actual blood pressure, whether or not you have high blood pressure or not. They do a diabetes check, and they check your cholesterol, and then they can tell you what your overall risk actually is. And I think there is little point in trying to make a pharmacological solution to the chap who will persistently carry on smoking, because the benefit that you have from the statin is really very marginal compared to the enormous benefit of kicking the fags in the bin. So I think there is little point in actually going for lots of pharmacology when in fact the basic lifestyle maneuvers won't be adhered to. So of course, if you're a diabetic, that's out the window. You already have a major risk factor and you really should be on a statin. But if we're talking about your well and worried listener, then over the age of 50, I don't think it's automatic that I would give everyone over 50 a statin. I've done it to myself. I'm a believer in the data. If someone was willing to accept a statin, I would give it to them, but I would have checked their blood pressure. I would have checked for diabetes. I'll check their lipid profile, because I want to be sure of what the overall risk is, so that if they have a side effect, I can say, look, this is why we want to do it. Do you want to put up with the side effect? Or actually, listen, you're at the low risk end of the spectrum at the age of 50, and I accept you've tried the statin and we can't make it work for you, so stay off it, no problem. So it isn't an imperative. Very different if you've had a stent or if you've had a heart attack. Then I will twist everyone's arm to take a statin because the evidence is so much stronger. The benefit, relative risk reduction, in other words, how much of your risk can you take away, is the same for primary prevention and secondary prevention. So in other words, whether you've had a heart attack or not. The absolute benefit, of course, is much greater if you started off at a risk of 30% and got a 1/3 reduction, you've gained 10%. If you started off with a risk of 3% and you gained a 1/3 reduction, your absolute gain is only 1%. But that doesn't mean that 1% is not important when you want to live to 90 rather than 80.
Sure.
I think it's still worth it.
We've had a caller ask, if you have a well woman test, does that include the measuring of your cholesterol in general?
Well women test depends very much on where you actually go. So I would say that a health check should include a cholesterol measure. What you get at your pharmacy is usually just an absolute total cholesterol. And if that's low and you have no risk factors, leave it. But if, in fact, it's above 5, I would ask your GP, well, what's my ratio of good to bad cholesterol? What is my overall risk profile before you give me any tablets? It really has to be part of, in my mind at least, an overall risk assessment, because there is really no point in giving a statin and taking that every day religiously when you're not addressing some of the other important risk factors.
Thank you very much. Thanks for talking to us. Dr. Iqbal Malik there, setting out the stall. I mean, you don't often get doctors say, I believe in this so passionately, I've done it myself, and I've given it to myself, which is what he said. Put himself on statins at the age of 46. But no risk.